You're listening to the Mother to Baby podcast, medications and more during pregnancy and breastfeeding. Ask the experts with your host, genetic counselor and mom of four, Chris Stallman.
This episode contains evidence-based information that's current as of the day recorded and may change as more data becomes available. To get the very latest information about this topic or other topics in pregnancy and breastfeeding, please contact a mother-to-baby specialist at 866-626-6847, by text at 855-999-3525, or through our website at MotherToBaby.org. Welcome to another episode of the Mother to Baby podcast. My name is Chris Stallman, and I'm a genetic counselor, a mom of four, and a teratogen information specialist. So what that means is that I give information about exposures that can happen before pregnancy, during pregnancy, while breastfeeding, and in cases of adoption. And we at Mother to Baby talk to anybody, so patients, family members, healthcare providers, and members of the general public. And an exposure can be anything. So it could be a medication that you take. It could be a chemical or something else in your workplace. It could be a vaccine. Or it could be something like alcohol. And in fact, today's episode is very special. It is one of the first of a 3-part series about fetal alcohol spectrum disorders, otherwise known as FASD. By the end of this episode, we hope you'll learn all about FASDs and can answer questions like, what are FASDs? And what are some of the features, both physical and cognitive, of someone living with an FASD? To talk with us today, I'm excited to introduce our 2 expert guests. The first is Dr. Kenneth Lyons Jones, one of Mother to Baby's founding members. Currently, he is a professor of pediatrics at the University of California, San Diego. And back in 1973, Dr. Jones was one of the first doctors at the University of Washington who first identified fetal alcohol syndrome, FAS, in the United States. We also have Dr. Christina Chambers, program director of our Mother to Baby California affiliate. She is a professor of pediatrics at the University of California, San Diego. She is a world-renowned perinatal epidemiologist who has been heavily involved in research surrounding alcohol exposure over the course of her very decorated career. Dr. Jones and Dr. Chambers, thank you so much for joining us for the podcast. Dr. Jones, I'd like to start with you. Can you tell our audience a little bit about what FASDs are?
FASD stands for Fetal Alcohol Spectrum Disorder, and Fetal Alcohol Spectrum Disorder in and of itself is not a diagnosis, it's an umbrella term. And under that umbrella are 3 diagnoses, and they are fetal alcohol syndrome, as at one end of the spectrum. At the other end of the spectrum is alcohol-related neurodevelopmental disorder, and between the 2 ends of the spectrum is something that we call partial fetal alcohol syndrome. So fetal alcohol syndrome was first described in 1973 in Seattle, Washington, and it was used to describe a condition in a baby who was born to a woman who drank alcohol during her pregnancy, or the baby was exposed prenatally to alcohol, who had a very specific pattern of abnormalities. And those abnormalities included being undergrown with respect to both height and weight, to have a small head circumference, and to have some very specific but very subtle facial features, which included 3 things. The first being short palpebral fissures. The palpebral fissure is the measurement from the inner corner of the eye to the outer corner of the eye. And in individuals who have the fetal alcohol syndrome, that's shorter than it's supposed to be. And the other 2 features are a smooth philtrum. The philtrum is the area from the base of the nasal septum. So that's right there to the red part of the upper lip. And you can see in me that I have these two vertical ridges there. And individuals with the fetal alcohol syndrome lack those vertical ridges, so it's completely smooth across there. And the vermilion border of the upper lip, that's just a fancy term for the red part of the upper lip. The upper part of the red of the upper lip, as you can see with me, has this Cupid's bow configuration where it goes up and then drops down and then goes up again. And in individuals who have the fetal alcohol syndrome, that vermilion border is smooth and it's thinner than it should be. So it lacks that Cupid's bow configuration. So individuals with fetal alcohol syndrome have the growth deficiency, the small head, and then they have these three facial features. And in addition to that, they have problems in terms of neurodevelopment. And then at the other end of the spectrum of the fetal alcohol spectrum disorder is alcohol-related neurodevelopmental disorder, and that is used to describe individuals who have been prenatally exposed to alcohol, so they have the same exposure to alcohol that individuals with fetal alcohol syndrome have, but they do not have the growth deficiency. They don't have the small head circumference. They don't have the facial features, but they do have all the neurobehavior problems. And then in between the two are individuals who have what we call partial fetal alcohol syndrome, and they are individuals who have some of the features of fetal alcohol syndrome, but not enough to say that they actually have the fetal alcohol syndrome.
Sure. So you've described very well the physical features associated with the FASDs. Can you tell us a little bit more about the cognitive features?
So kids with fetal alcohol syndrome have very, as you say, they have very specific cognitive abnormalities, and they have some pretty specific behavior problems. And you can get the diagnosis basically by having one or both of those abnormalities. So the cognitive abnormalities they have are they have an IQ score of equal to or greater than 1.5 standard deviations below the mean. So that's an IQ score of about 78, 79. So not below 70 necessarily, which is what we usually use to describe intellectual deficiency, but still an IQ score which is significantly below the average. So they have cognitive abnormalities. And then they can have problems with executive functioning. They can have problems with memory. They can have problems with learning. Specifically, they have difficulties with math frequently, and they have visual spatial problems, and those are the cognitive abnormalities that children with fetal alcohol syndrome have, or alcohol-related neurodevelopmental disorder have, and then they sometimes have problems with self-regulation, and so that involves really mood and behavioral regulation. So. Problems with things like temper tantrums are the big kinds of problems that these kids frequently have.
How were the effects of alcohol use during pregnancy first discovered and described in the literature?
Well, it like so many other things, it was basically luck, I guess you would call it. In 1973, I was a fellow at the University of Washington in Seattle with a brilliant pediatrician by the name of David Smith. And he was called one day down to the King County Hospital, which was the county hospital of Seattle, to see a group of children, 8 children, who had been prenatally exposed to alcohol. Who the head of the outpatient department at King County Hospital, Dr. Shirley Anderson, thought they looked a little bit different. They all were intellectually disabled, but in addition to that, they looked a little bit different. So she asked him to come down and take a look at those kids, and I was his fellow. So I jumped in the car, and the two of us went down there, and there were these 8 children all sitting around the edge of the room, and they all had intellectual deficiency, but 4 of those kids had this very specific pattern of abnormalities that I've just described to you. And then we went back, and they were all intellectually disabled, but the other 4 did not. They were just intellectually disabled. And then we went back to Dr. Smith's office, where we looked through his unknown file, and we looked for the 3 features that seemed to be most consistent in the 4 children that we saw. And 2 kids fell out of his file with the same features, and both of their mothers were severe alcoholic women. And then the next week, he went off to Ohio to be a visiting professor, and he saw another child back there with the same features. And while he was away, I was asked to see a child with a congenital hip dislocation at the Children's Hospital in Seattle, and that child had the same features and was also born to a woman who drank heavily during her pregnancy. So, in a period then of about 3 weeks, we saw these 8 children, all of whom were born to women who drank heavily during pregnancy. So it was just fortuitous. There's no question about that.
I want to switch gears a bit now and talk about how common FASDs are in America. Dr. Chambers, you've been involved in research about FASDs for years. Can you tell us a little bit about that?
Yes, it's been a really important topic worldwide, but certainly in the U.S., to try to understand how common FASDs are, for the important reason that it's very difficult to measure if we have done a good job in terms of preventing them if we really don't know how frequently they occur. But there are many challenges in doing that. It in many ways is a hidden disorder. Or set of disorders, in that it's sometimes difficult or stigmatizing for a woman to admit that she has consumed alcohol in pregnancy. It may be difficult for a pediatrician or a general practitioner to recognize some of the signs and features of FASD. And we know from the literature that oftentimes children are either misdiagnosed or not diagnosed at all for FASDs. So a few years ago, to try to address at least one part of this question, how common is this? We were funded with some colleagues at University of North Carolina to do a study in the U.S. in 4 regions. So of course, it would be very difficult to do this in every state in the country, but to do this in 4 kind of representative regions where we looked at children in the 1st grade in school. So I chose 1st grade because this is a time at which some kinds of learning abilities of children could be measured, but close enough to young age that we might be able to get at least close to accurate information from the mother about exposures during pregnancy. And so in this study, over a 2-year period of time, what we did was enroll families who had children in the normal 1st grade in school at these 4 sites, some rural, some urban, and we interviewed the mothers about their alcohol use in pregnancy. And then the children got a very specialized exam. So they got a special exam for the physical features of FASD, which can be very subtle and sometimes require quite a bit of expertise to be able to recognize them, for growth. And then importantly, the children got a whole battery of neurobehavioral tests to be able to look at how they were performing, both cognitively and behaviorally. And what we came up with was across all 4 regions about a range of 1 to 5% of all children who participated in the study in that 1st grade age range had evidence of having an FASD. So this was really not surprising to us, but I think astonishing to many people that this is as common as what's quoted for autism spectrum disorders, but not recognized, I think, by the general public as being that common. And this 1 to 5%, meaning as high as 1 in 20 children in normal first grade in school, importantly, out of the children that were identified in this study, only 2 had ever had a previous diagnosis. So all of the remaining 220 had no idea that any of the deficits or difficulties or features their child might have could be related to alcohol. So pointing to what I said earlier, that this is a highly under-recognized disorder, leading to lack of interventions and lack of prevention activities that could perhaps help try to deal with this.
And thank you for sort of flipping that number on its head when you were talking about the percentages. I know you mentioned up to 1 out of 20 from the information in your study. That would be that 5%, with the 1% being closer to 1 in 100. So is there any insight or, any feelings or theories that you've developed personally or professionally over the years? Why is alcohol consumption during pregnancy still ongoing? Why are we continuing to have this issue in the United States?
Yeah, I think and it is not just the United States. I think it's other countries as well. It's a part of our social fabric, alcohol use. It's, culturally part of so much of social interaction. And we've seen, when you look at national survey data, we've seen over the years that where maybe 50 years ago, women would not drink as much as men do, that there's been this sort of gradual increase in women keeping up with the men. And so an increase in alcohol consumption just in the general population of women. And in particular, an increase in binge drinking, what we call binge drinking. So an increase in drinking 3, 4, 5 or more drinks on an occasion. So what we call heavy episodic drinking, which is thought to be the riskiest pattern of drinking in terms of pregnancy. So you have a population where 50% of women of reproductive age in the U.S. Drink something. They consume alcohol as part of their everyday life, and 50% of pregnancies are not planned. And so you have the kind of perfect storm, if you will, that it's highly likely that somebody who has not planned pregnancy will continue to drink as they normally would until they find out they're pregnant. So you have 4, 6, 8, maybe 10 weeks where somebody will continue to drink as they usually do. So that's one reason why this happens. And there are other reasons as well. I think that sometimes people get the miscommunication, even from healthcare providers sometimes, that it's really only people who are need to be in, residential treatment or have a severe substance use disorder, who are at risk of having an alcohol-affected pregnancy, when in fact that's not the case. It's the quantity and frequency and how long that a woman drinks in pregnancy. Even if it's not impacting her life in other ways, it can impact the development of the baby.
So as you mentioned, several factors here. Sometimes you have this perfect storm of more people are drinking a lot. So about half of all pregnancies in the U.S. are considered unplanned. And then, you have this other piece of it. I know you said, a couple of weeks. Reminder to the audience, that very often it takes some time to find out that you're pregnant. Like you said, you might not know going in. Very often, it can come around maybe 6 weeks, maybe 8 weeks, and later for some folks. So, lots of different things going on. What are some of the newest research discoveries around FASDs?
Well, there's a lot of interest, of course, on the treatment side, trying to obviously the solution, the simple solution is don't drink during pregnancy, but we've not been very successful in making that happen or improving those kinds of exposures. And so other avenues that have been used that are successful and continue to be successful are to try to intervene in women who are not pregnant but have the potential to become pregnant. So there's been quite a number of successful studies that can be implemented in general practice on intervening with women who drink normally and who may or may not be using effective birth control. So education, but also interviewing to say the two things you can do, or the combination of the two that you can do to prevent an alcohol-exposed pregnancy, is to reduce your drinking, certainly not to binge drink, even though you're not pregnant now, but you have the potential to become pregnant, or to effectively prevent pregnancy by using highly effective contraception. So the combination of those two, I think there's old data, but newer data continues to support that this is an effective intervention in terms of preventing an alcohol-exposed pregnancy. On the treatment side of it, there are lots of researchers working hard to develop tools that parents and teachers can use to help intervene on the behavioral, and cognitive deficits that these children can have. There has been a lot of interest and quite a bit of research in looking at supplementation, dietary or vitamin supplementation. And one that has been of high interest and a focus has been choline. So it's a B vitamin that has a lot of benefits. It's important in our available in our diet, but there has been research both in prenatal supplementation with choline in women who've already had alcohol exposure, and in postnatal supplementation of children with FASD with choline that has shown benefits. It's not going to take everything away, it's not the magic bullet, but there has shown some benefits in terms of improving outcomes for those children. So that I think is important in terms of giving people more tools.
Excellent. And it absolutely, makes sense when you think about it. Anyone who's been pregnant or encountered someone who's pregnant might have heard of pregnancy brain, sort of when you're a little bit more forgetful during that pregnancy time. And the studies have indicated that in some cases that could be a lack of choline. So absolutely makes sense that choline has some of that connection. And as you said, not a cure-all, but something that might be able to help. And that is really exciting. So you fit the bill there perfectly. Awesome. Do you think there's going to be more breakthroughs in the prevention of FASD outside of, what we know? So things like the nutritional component, which we're learning more about, knowing that truly, the only amount of safe alcohol in pregnancy is 0. So avoiding drinking altogether. But do you think that there's going to be other breakthroughs in the prevention, or what should we be thinking about or looking towards for the future?
I do. I'm hopeful. I think I think it's important to realize that it's a fact of our society, and we're not going to have prohibition for women. So we have to deal with this. One of the things that I think that is really important is obviously we want to encourage people for every reason under the sun to plan pregnancy. That has broad benefits well beyond alcohol exposure, but what kinds of technologies can we develop so that we recognize pregnancy earlier? So is it possible to know on the date of conception by, wearing a Nora ring or some kind of biomarker that would tell you that you're pregnant much earlier than you would normally find by, a routine pregnancy test, or thinking, oh, I've missed a period and, maybe I could be pregnant. If those kinds of technologies could be developed and deployed, there might be an opportunity then to alter your behavior very early and long before those first very critical weeks of early development of the embryo are taking place. I think there are going to be and are continuing to be improvements in technology in diagnosis. So one of the things that has shown promise is we have this difficult situation in the U.S. and elsewhere in the world where there's not a lot of expert teams who can actually address, the whole child and determine whether or not a child seems to be affected by an FASD. And one of the particularly difficult issues is if the child has the facial features or other physical features, that there are not a lot of trained clinicians who can recognize those features. So there's been quite a bit of work on using 3D facial imaging. So taking these, specialized photographs that allow you to take some measurements of the face, but it also can pick up subtle differences that even the clinician can't see or doesn't know they see. So it's an opportunity to be able to say, can we use something that nowadays is readily available on your iPhone, a 3D image of a child, to be able to differentiate between a child who may be affected by alcohol and a child who is not. And if we can do that, and especially if we can do that in as young as we can possibly do it. I mean, if you could do it in infancy, then we have opens up the door for many more types of early interventions that can actually benefit the child and change that trajectory for that child in ways that are positive. So I think those would be probably the two areas that I see some real promise.
And that's really exciting. I know that some of the facial technology software has been around for a while, but as things continue to improve, it's exciting to hear, like you said, there might be something very subtle, either that, someone hasn't seen very often or something that they don't even realize is there because they're looking at perhaps a bigger issue. I'd like to see more of a normalization of asking about alcohol use because it is a tricky thing, from the patient perspective, from the provider perspective. I want to see, and I hope that there's a way to go about it where there is more sharing of that information with less judgment, with less stigma, and with less fear. How do we get at this information in a way, that is beneficial to everybody because early intervention is so important. And so, Dr. Chambers, the last question that I want to ask to you is, can you explain to us the importance of that early intervention for FASDs?
Well, certainly the earliest intervention is something that can prevent the alcohol exposure to begin with. Once a woman finds out she's pregnant and she's going to her OB provider or her, whoever the provider is for her pregnancy, just as you said, being able to feel completely comfortable and as part of routine care that you ask in a non-stigmatizing way about alcohol exposure in pregnancy, couching it in ways that are make the woman feel more comfortable that this is an extremely common exposure, and that most of my patients tell me they have had something to drink, and so can you tell me a little bit about what you normally drink when you're not pregnant, and begin there because that doesn't carry the stigma with it, and then in the period of time before you knew you were pregnant, what you had to drink there. I think then the issue is, what do you do about it?
Yeah.
So that's a challenge. And I think for a pregnant person, first and foremost, what the healthcare provider's message then is, okay, this is very, very common, that people have had a couple of margaritas on a Saturday night, and then a couple weeks later they find out they're pregnant. The most important take-home message here is, once you now know you're pregnant, that avoiding alcohol entirely is the best approach. And coming across with that in a confident way to a patient, that it's not, well, maybe you would want to avoid alcohol, just avoid alcohol. We don't know, we have no idea why one person's baby is more susceptible than another's. We have, we can try to develop threshold data all we want, but we really can't say for an individual patient, you can drink 2 drinks a day and the woman next to you cannot drink at all. So we just say, why take the risk? Just avoid it entirely throughout the rest of your pregnancy. Then the challenge is, do you need help?
Yeah.
And I think that is a big challenge in our country and elsewhere, is if you do need help, how can you get it? And how can you get it that's sensitive to this issue in pregnancy? Because it's quite different. I think it's the feeling for the woman and for the family and so on can be quite different in terms of how you deal with that. And I do not think we have enough very tailored resources for pregnant women to help try to deal with this very sensitive issue. I think that would be critically important. And then the same thing trails out to the end of the pregnancy after the baby's born. If there's an intervention that the child could benefit from, you have to know that the child could benefit from it. So if prenatal exposure isn't asked about, if it isn't acknowledged, then you don't know that that child is the child that needs to, or potentially could be the one who could benefit from the early intervention, because you can't test them for cognitive abilities, at 1 day of age. But you can say, that you've had this amount of alcohol exposure. We might want to do everything we can as when the baby is quite young to optimize that child's development. So I think it all leads back to the question of destigmatizing asking the question and proactively trying to develop resources that help address the response to the question.
Agreed. Dr. Chambers, before I let you go, is there a final thought that you would like to leave our audience with today?
Yes. Here we are sitting some 50 years after this disorder was first recognized, not that it didn't exist for centuries before that, but 50 years we've known, and we've not made a whole lot of progress in preventing it. And I think it's actually alcohol consumption, if you look at the numbers, was exacerbated during the pandemic.
Sure.
Among women in particular, and has not seemed to subside. So we have evidence now that this is probably the most common developmental disability that we know of, and we know it's completely preventable. So we need to take it out of the shadows and say this is the reality, and we as a society have to do something about it to help women and to help families be able to do better by their children. I think it can be done, and I think we should do it.
I absolutely agree. And I so appreciate, hey, we know it's going to happen. We want to prevent it. We know where the ideal is. However, we need to continue to meet folks where they are. We need to recognize that it's going to happen, and how can we best help everybody involved. Thank you, Dr. Chambers and Dr. Jones, for making that the message here, that, this is something that we can recognize. There are ways we can help, and we all collectively need to do a better job. And to our audience, thank you so much for joining us. Now's the time to think back at our original question we proposed at the beginning of the episode about the features of someone living with an FASD. Can you name some of the physical and cognitive features that were mentioned by our guests? Test your knowledge now and earn some continuing education credits by clicking on the link in our show notes. We hope you'll join us for our next episode as we continue to talk about FASDs in our 3-part series. Be sure to hit that subscribe button so that way you never miss a new episode, and you can go back and listen or re-listen to some of those older episodes as well. You can find us on iTunes, Spotify, Audible, or however you like to listen to podcasts. And if you want to be on the podcast, or if you have an idea for the show, we would love to hear from you. Please feel free to email us at contact@mothertobaby.org. And MotherToBaby is here to answer your questions about exposures before and during pregnancy, while breastfeeding, or if you have questions about exposures and adoption. You can reach us by phone at 866-626-6847. By text at 855-999-3525. You can visit us on our website, MotherToBaby.org, and there you can chat with an information specialist. You can look at our many blogs, information pages, our hundreds of fact sheets that are available free in English and in Spanish. And you can also listen to our podcast or find out how you can participate in our pregnancy studies. If you would like to support the Mother to Baby podcast, as well as all of the ways we get critical pregnancy and breastfeeding health information to you at home, we have a new way to do just that. Encircle is our new monthly giving society that helps ensure we can continue to provide our services at no cost. Join the community today and encircle parents and babies in health. Members will be recognized on the podcast and website. Visit mothertobaby.org/donate today. Until next time, remember, Mother to Baby is here for you. Take care.
Mother to Baby is a service of the nonprofit organization of Teratology Information Specialists and supported by the Health Resources and Service Administration of the U.S. Department of Health and Human Services. It's made possible through generous donations from listeners like you. To learn more about Mother to Baby, please visit mothertobaby.org.